Okay, let's go over the pediatric cardiac arrest algorithm. So again, you're the ACLS team leader. You're gonna try to use your crew resource management and place personnel and equipment in areas that function well. If you're the only ALS person, then you know you have to initiate the airway and then ensure that you're doing all the rhythm recognition and calling out the rhythms. You're also going to be the one that's maintaining the the tempo and control of the situation. You want your O2 IV EKG on. You want your defibrillation pads on. You want to have your end tidal deployed. You want to have all your airway, um, ALS airway, and a backup and bailout airways all ready for you. You want your medications all ready to go. And um, as you initiate your protocol through this scene, ensure that everybody is performing the CPR and bag valve mask ventilation according to standard. Then identify on the EKG what is that rhythm. Is that rhythm a ventricular fibrillation or a pulsus ventricular tachycardia? And if it's so, then we're going to go ahead and deliver the shock. Now, if you witness a patient that goes directly into cardiac arrest, they were um, had a pulse, and all of a sudden they go into cardiac arrest, you go directly to shock, okay? Directly into shock. If they are already receiving CPR and you're applying everything on, continue with that CPR, try to establish your IV axis, and then you're going to go into that shock, okay? And so the first shock, you're going to go with 2 joules per kilogram. So now when we establish that first shock and you've established the IV axis, if that person is still in the shockable rhythm, you'll then give your epinephrine, and that's going to be 0.01 milligrams per kilogram. So you give that epinephrine IV, you can double that dose IO, double the dose ET. And then you're going to continue, and then at that 2 minutes, you're switching out with people and you're reassessing that rhythm to make sure that it's shockable, and then we're going to shock at 4 joules per kilo. We're going to continue to do this drug shock regime and switching out every 2 minutes. And you're going to continue your subsequent doses up until you hit 10 joules per kilo. That's your max or your adult dose. Where you consider your second drug of choice after you're giving you epinephrine is your amiodarone, and we're going to go ahead and give that amiodarone 5 milligrams per kilogram, and we'll give that as a bolus, and we can repeat this after the epinephrine after we give it. So it'll be 4 minutes later that you'll give, after your first dose, you'll give your second dose, 5 milligrams per kilogram. We can also consider another antidysrhythmic, which is lidocaine, which you give 1 milligram per kilogram, and then you can go ahead and give another. If you are able to convert these people either with amiodarone or lidocaine, then you would consider running an amiodarone drip 1 milligram per minute, and we can titrate that up once you have converted them and you have ROSC. Or you can go with lidocaine, and you can use a maintenance dose here. They're saying 20 to 50 micrograms per kilogram. So again, I would consider you could run a 1 milligram per minute infusion of lidocaine. Just contact your base station medical control as to what they would like you to continue uh, as a maintenance drip dose. Now, if the patient then changes and it goes out of a shock rhythm into something called asystole or PA, we don't shock this anymore. We stop defibrillating if they're in asystole or PA. Now, PA is anything that is not ventricular tachycardia or ventricular fibrillation. So if it's an idioventricular, an agonal rhythm, if it's an accelerated idio, if it's an atrial fibrillation, if it's sinus tachycardia, sinus brady, sinus rhythm, if it is not a shockable rhythm, the VF or VT will follow the asystole or PA algorithm. And that would mean that you would just continue with epinephrine doses and then consider the possible causes on both algorithms as you go down. Is there anything that you can change or fix? Then we want to do so. If your patient then changes out of this PA or asystole rhythm and goes into a shockable rhythm, then by all means, now when you check your rhythm at 2 minutes, please go ahead and continue that shocking jewel setting, whichever jewel setting that you started with, increase up. If the patient then has return of spontaneous circulation, let's go ahead and get a good set of vital signs. That means blood pressure, pulse. Find out if there's any spontaneous respirations. Go ahead and make sure you're measuring your end tidal CO2 capnography and capnometry. You want that waveform and that number that's coming out. We're going to see a little bump in that. It's going to go way up, and we want to start to bring that respiratory rate up so we can off gas that. Think about vasopressors if you need to bring that pressure up, 20 cc per kilo, fluid boluses, and then get on the horn and communicate to the receiving facility or your medical control and advise them as to what you have. So again, let's go ahead and consider, let's say we have a 3-year-old and is 15 kilos, and let's see whether or not we can flow through this.